to Part A, dealing with the respiratory. Looking at overall this part is looking at the anatomy. We'll also follow up by looking at the function of the respiratory. Some of the major clinical disorders that we do see associated with the respiratory system. The main purpose of the respiratory system is to help with the gas exchange. You are trying to get oxygen into the tissues at the cellular level because it's required for certain metabolic processes to produce ATP, which is energy for the cells to carry out all the different reactions. One of the byproducts of certainly cellular respiration, the process of breaking glucose down to produce energy, is carbon dioxide or CO2. And this is a waste product. You need to get rid of it. And so the respiratory system is going to be supplying the oxygen, getting rid of the carbon dioxide. The respiratory system also does play a role with things such as smell. When we talk about the respiratory system, we can break it down into two components, if you will. Those components are going to be the respiratory system versus the circulatory system and how they interplay, and whether you are talking about the exchange of gas in the lungs, the exchange of gas between the tissue and the blood, and the role that the circulatory system plays in this is how do you transport the oxygen, CO2. So pulmonary ventilation, which is often referred to as breathing, is just that movement of air into and out of the lungs. External respiration is the exchange of CO2 and oxygen between the lungs and the blood. Then you're going to transport that, how? By the circulatory system, so that then internal respiration can occur. That is the exchange of oxygen and carbon dioxide between the capillaries, basically throughout the body other than in the lungs, and that exchange with the tissues that are surrounding them. Just so you know, sometimes you may hear the term cellular respiration. That is something that is totally different. It occurs down in the cells, and it is the process of breaking glucose down to generate ATP or energy for the cells. So that's a totally different process that will occur. When we look at the major organs involved with the respiratory system, we divide it to upper respiratory and lower respiratory. Upper respiratory will be comprised of the nose, the nasal cavity, your sinuses, the pharynx. And then the lower respiratory is the larynx, the trachea, the bronchi, and all the various branches, the lungs, and the. So up here is the upper respiratory system, and then down here is the lower respiratory components. The upper respiratory system, this chart just goes through. It names the various structures, gives a brief description of it, and what the function is for that particular. And it continues now also with the lower respiratory. If we start off with the upper respiratory, the nose and the paranasal sinuses. The nose is the only external part. You see, what's the function of the nose? Well, obviously, it provides that initial passageway of air into the body. Something that's very important is that it will moisten and warm the air as it enters. In a very dry climate, that's very tough on the lungs. It will pull moisture out of the lungs, so you want to moisten it before it goes in. It also helps to filter and clean that air. You do not want to have particles going down into the lungs. As I said, it also the nose will play a role in helping with speech. Olfactory is the sense of smell. So the external nose, this area obviously that you see. The nostrils are referred to as the nares. It is going to be forming. Excuse me. There's a septum in the middle that does separate the two sides. The nasal cavity is going to be found behind the external nose. As you can see, the nasal cavity is formed by various bones such as the ethmoid, the sphenoid, hard palate. The nasal cavity is lined with hairs that's going to help filter the air as it goes through. The idea behind it is once again to keep particles out of the lungs ultimately. You do have receptors here for olfaction, sense of smell, cells that are producing mucus, which the generation of mucus once again will help to move substances out of the respiratory system. The mucus does produce lysozyme and defenses. These are chemicals that do play a role as part of the first line of defense of the innate immune system, and that these will essentially, for any foreign substance such as bacteria, it will break them down. The air is going to be warmed. In the nasal conchi, this is projection. It helps. There's 3 different areas of it. It's going to help move the air through as it circulates. As you breathe in, if you follow the laser, it's going to breathe in, even though there's not a picture here, and it gets the air kind of swirling around, so it spends more time in the nasal cavity. That gives more chance for the air to be warmed, to add moisture to it. In terms of the sense of smell, of those nerve endings that are receptors that allow you to pick up the sense of smell. So during inhalation, you're going to heat the air, you're going to moisten the air, you're going to filter the air. When you exhale, you basically are helping to reclaim some of that heat and moisture, so it's not all lost. There are 4 different sets of paranasal sinuses: the frontal, sphenoid, ethmoid, and maxillary sinuses. What the sinuses are doing is they will help their air cavities. They will help lighten the skull so the bone's not as heavy. You can hold your head up. It will secrete mucus that helps to warm. If you have a sinus infection, what happens is that some of these, such as the frontal sinus, may become filled with mucus that is infected, and this should be filled with air. This is another cross-section showing the nasal cavity. If you have inflammation of that nasal mucosa, what can happen is you can have an infection that then will spread from the nose to the throat, then down into the lungs, into the chest. The pharynx, this is going to be running back of the nasal cavity down past the back of the mouth to the larynx. Near the esophagus, it's composed of skeletal muscles. It can be divided into 3 different regions. So here's your nasal cavity. The uppermost and most superior area is the nasal pharynx, followed by the oropharynx, as you can see. Here's your mouth. Here's when you swallow food, it's going to pass through the oropharynx. And then the laryngeal pharynx is right here. Between both the respiratory and the digestive system. So in the nasal pharynx, you've got the air coming in from the back of the nasal cavity. You do have the soft palate and the uvula. That's going to help when you're swallowing. It's helping to guide the food to go down properly. You do have the pharyngeal tonsils, which are also commonly referred to as adenoids. And then you have your pharynx tympanic tubes or eustachian tubes or auditory tubes, whichever you wish to call them. Those are going to drain in this area as well. That comes from the middle ear. It helps to equalize pressure, drain into the nasal pharynx. As I said, the oropharynx comes near the back of the mouth, and so it's shared with the digestive system whenever you swallow food, or if you're breathing through your mouth, it will go through here. So it goes from the soft palate to the epiglottis. You do have both the palatine tonsils and the lingual tonsils are associated. The laryngeal pharynx is for both food and air. It is posterior to the epiglottis. Once again, this is showing things such as the palatine tonsils here, pharyngeal tonsils here. Over here, your lingual tonsils, and the three different components of the pharynx. If the adenoids are infected and very swollen, they can essentially end up blocking the air passageway in the nasopharynx. That would force the individual to be breathing through their mouth. And whenever you're breathing through your mouth, one of the problems with that is you're not adding as much moisture, you're not warming it, and you're not filtering that air before it reaches the lungs. So it can set up the possibility of infections within the lungs because you're not cleaning that air before it gets there. If this is a chronic condition, meaning it's a long-term condition of swollen adenoids, they may end up deciding to remove them because it can long-term interfere with speech, it can interfere with sleep. The lower respiratory system is the larynx, the trachea, the bronchia, and the lungs. We divide it into two zones, the respiratory zone, which is where the gas exchange is actually going to occur, and the conducting zone, which is basically, think of it as the highway of transporting the gas to and from the respiratory zone. In that portion, you're going to be, once again, warming the air, humidifying it, trying to clean it, so that it gets to that exchange site. The larynx, essentially, this is your voice box. There's three main functions of it. It continues with providing the airway down to the lungs. It also has a route for food, and this is also where your vocal cords are. So it does deal with. There is thyroid cartilage that helps to make this up. Some of this is what we call cryoid cartilage. It's ring-shaped. We do give different names to the cartilage of where it's located at. The epiglottis is elastic cartilage. When you are swallowing, it will cover the laryngeal inlet so that food is not going to go down into the lungs. This picture just shows how you can locate such as what's referred to as Adam's apple, the laryngeal prominence right here, and where some of the other cartilage is located along the larynx, using some of your bones as markings as markers. Excuse me. So in this diagram, you can see here's the laryngeal prominence right here, or the Adam's apple. You've got the thyroid cartilage. Yeah, here's the choroid cartilage here. Way up here at the top is the epiglottis. The vocal folds, these are ligaments that form these. These are the true vocal cords. Basically, what happens as these folds vibrate, it produces sound as the air is rushing up. The false vocal cord, or vestibular folds, these help to close the glottis when you're swallowing. They actually, even though they're referred to as false vocal cords, do not have anything. This just talks review as to the type of cells that form the part of the larynx. As you can see here, a photograph of some of the cartilage that helps sagittal view as well. Here's a picture showing the vocal cords. This is the vocal cords with it closed, and here's with it open. As the air is moving from the lungs upward and out, it causes vibrations, and that's what causes sound. There's differences on loudness and pitch and speech. It all depends on how the opening and closing of the glottis, what's the force of the air that's coming through, what's the tension involved. You can also amplify and enhance sounds depending on the chambers of the nasal cavity, the oral cavity, your sinus cavities. And then some of the sound you manipulate by the muscles of the tongue, the muscles of the lips, the soft palate, and the pharynx. There are times when the vocal cords can act as a sphincter that prevents air passaging, and that can have other effects when that happens. It can prevent exhalation. Oftentimes, if you forcefully are closing, preventing air through, it does have effect on other muscles in other areas of the body, such as in the abdomen. That will typically cause those muscles to contract. That can help with things such as that. If you have inflammation of vocal cords, you have classified as laryngitis. Anything ending with itis, itis is inflammation. That would cause the vocal cords to swell, and that's going to interfere with it vibrating, which means it's going to interfere with the sound. You're going to lose your voice, basically. What causes laryngitis? It may be due to overusing your voice. Maybe you're at a concert and you're really yelling and screaming loudly and using your voice much more frequently and louder, forcefully than what you normally do. It can also be caused by viral infections. It can be caused by bacterial infections. It can be caused by if you inhale irritating chemicals. Sometimes very, very dry air can cause. Beneath or below the larynx is the trachea, and it will extend down. Eventually, it will divide at the very bottom. How long is it? It's about 4 inches in length. It is not quite an inch in diameter. You have 3 different layers, as we've seen throughout A&P. There's smooth muscle that is comprising part of the trachea that will contract, like whenever you're coughing, that smooth muscle contracts. It helps to expel mucus to get substances out of the lungs. The last ring of cartilage is expanded, and the cartilage then is going to branch. This is called the green area. Coughing, severe coughing, if something comes in contact with it. This is just showing that you have with the trachea, if you are looking, this is the anterior or front section. The trachea is in front of the esophagus. You'll notice that the cartilage is not all the way circular around. There is right here some muscle from the esophagus, so that if you do swallow something really large, it does give there's some give and take on this side right here. This is showing a nice picture of a micrograph of the wall of the trachea. One thing I want to point out, right along here are all of the cilia that help to move the mucus that's being produced. It will help move it up, trying to prevent it from getting into the lungs. The whole purpose is protect the lungs. You do have goblet cells in here. These are the cells that are producing the. What happens to someone, a clinical setting of this where somebody smokes? What that does is it's destroying the cilia. The cilia move in kind of a rhythmic fashion, kind of visualize seaweed moving as the waves are coming in, and that's helping to move substances that you may have inhaled, getting it out of the lungs. You're producing mucus, get that mucus out. If you're a smoker, it destroys the cilia, so there's no way of getting that mucus out of the lungs. The only way you can do it now is by coughing, and that's where oftentimes you may have seen people or heard people that have that smoker's cough. It's their body's way of trying to get that mucus out. One thing you have to consider, if that is the only way to get mucus out of the lungs, if you're treating a patient, Do you necessarily want to give them medication that would inhibit the cough reflex? No, because if you do, they are no longer coughing. You might initially think, okay, that's good. No, it's not, because that's the only way they have of getting the mucus out of the lungs. What would happen is they would have a mucus fluid, they can't get it out. So you have to be careful, as always, what medication is going to be given to a patient depending on what other underlying medical conditions they may have. Obviously, if you obstruct the trachea, you cannot get air into the lungs, and the individual would suffocate if it's not removed. So hopefully everyone knows the Heimlich maneuver. It's a way of trying to forcefully expel air out of the lungs that will help them remove whatever the substance is that's blocking the airway. Oftentimes this happens when someone is eating. Once again, always listen to what your mother said. Eat small bites. Chew your food completely to help reduce the chance of choking on a piece of food. With children, make sure food is always cut up in very small pieces. It is something that everyone should know how to do. Hopefully you never have to use it. You do know how to do it. So the trachea then branches at the carina area, and then you have your primary bronchial tubes that one goes to the right lung, the other goes to the left lung. There's going to be a whole series of branching of the tubes essentially, and we refer to this as the bronchial tree. You're still trying to pass the air or transfer the air from the breathing it in down to the lungs, where you can get it to that respiratory zone, which is where change is going to occur. So the primary bronchi, you have the left and right. Like I said, those are going to the lungs. The right main bronchus or primary bronchus is wider, it's shorter, it's more vertical than the left side. When the main branch enters into the lung, then it's going to branch into the secondary bronchi, also known as the lobar bronchial. On the right side, there are 3 lobes, so it's going to branch into these 3 secondary bronchi. The left lung is slightly smaller than the right lung. It contains only 2 lobes. The reason the left lung is slightly smaller is to allow space for your heart. So each lobal or secondary bronchi will supply the air to one lobe. Once in the lobe, you're going to have further branching into what's known as the tertiary bronchi or the segmental bronchi, and then those are going to start branching, getting smaller and smaller. When the diameter is less than 1 millimeter, then we call them bronchioles. And then the terminal bronchioles, these are the smallest of all, because the bronchioles keep branching smaller and smaller until you get to the terminal bronchi, where the diameter is less than 0.5 millimeters. The diameter is getting smaller and smaller and smaller. So here's the trachea. The carina region is right here. You have this branching here is the primary to the left, the primary to the right. Now you have the secondary to service each of the lobes. So 1, 2, and 3. And on the left side, 1 and 2. And then the primary branches to the secondary, to the tertiary, finally down to where you have. Now you're reaching into the area of what's known as the conducting zone. You're going to have changing, or in this area you have changes that will occur. You're preparing to allow for the gas exchange to occur. So there's a difference between just moving air down versus the gas exchange to occur. In the respiratory zone now is where the terminal bronchi, they will feed into what's known as the respiratory bronchioles, which then move to the alveolar ducts, and finally to the place where you have to go to is alveolar sacs, which those contain a cluster, it kind of looks like a grape cluster of alveoli. It is at the alveoli where you are going to finally have the gas exchange. So as you can see, here's the terminal. You're moving on down. Each one of these individual, they look like grapes. These are the alveoli. This whole cluster, if you want to call it a cluster of grapes, this is the alveoli sac. So this is where on each one of these little grapes, each one of these little alveoli, that is where the gas exchange is. Once again, the membrane between the alveolar and the capillary is very thin. That allows for simple diffusion to occur. Remember, things want to go from an area of high concentration to an area of low concentration. This is also where you have the effects of pressure gradients. Things move from high pressure to low pressure. Surfactant that is present in this area that keeps the alveoli from collapsing. So you have lots of capillaries in this area. You have alveoli pores, which are helping to trying to equalize the blood pressure. You have macrophages in this area, which are trying to keep the area somewhat sterile. In other words, it's trying to engulf any foreign things that you may have. It's able to recognize that and immediately wants to not allow that foreign substance to move into your body. If you have gas exchange occurring right here with the blood system, if it gets into the blood, it can move anywhere in the body. So that's why you have such a high number of macrophages circulating through this area. Basically, I'm going to get you if you're a foreign substance before you can get into the blood. Here's another really kind of cool picture showing in alveolar sacs area. So once again, this is just showing how things will move according to concentration gradients. You are going to be having oxygen. So you inhale the airs in this area. You're going to have the oxygen that you just inhaled. It's higher concentration in the alveolar. It's low concentration in the blood. Remember, this blood has just come from the right side of the heart. It's already been throughout the body. So it's very low in oxygen here, high oxygen here. Things go from high concentration to low concentration. So the oxygen is flowing from the alveoli into the blood. The carbon dioxide, which is a waste product, has been picked up from throughout the body. It's high in the blood. It's low in atmospheric air, so it's going to flow out of the blood into the alveoli, so then you can exhale it. Essentially, that's what the gas exchange is going to be. When you look at the lungs, we do divide it into different areas, the apex, the base. The base is going to be the more inferior portion that is actually resting on the diaphragm. The apex, or the top, is going to be basically behind the clavicle. Like I said, the left lung is going to be slightly smaller than the right lung so that you can position the heart in there. And notice what this is just showing the orientation. Right lung, left lung. Here's your diaphragm that the base of the lung sits on. And up here's the apex. So right here would be the clavicles right in front. This is showing a cross-section of the lung. Once again, the apex here. Under the lab, or in your lab, there are also some additional pictures that I posted with pictures of dissections of sheep lung. It's very, very spongy in nature, so that it can hold a lot of air capacity. The volume of it is quite extensive. Obviously, you must have a very significant blood flow to the lungs, because that's what you're doing, is having gas exchange, and you're going to carry those gases in the blood. And then here's the position of the heart right there. Right here is kind of a nice picture. You can see here's the pulmonary trunk, and then here where it branches, the left pulmonary artery, the right pulmonary artery. So each of the lungs are further subdivided into different segments. Each segment has its own artery, vein, and bronchus. That's a benefit to you in case, hopefully not, but in case you have a disease and only one segment is disease, it's isolated, you can remove that one segment. Because it has its own artery, vein, and bronchioles, it's a little easy to separate, and you wouldn't have to remove the entire lobe or the entire lung. So like I said, the lungs are very spongy in nature. This shows an idea of color coding of the different segments. The pulmonary circulation, you've got those pulmonary arteries are delivering the blood that has been throughout the body. Remember, that should be reviewed from the circulatory system. Pulmonary veins are going to be carrying the blood from the lungs back to the heart. This is now very highly oxygenated, high concentration of oxygen. How this exchange occurs is going to be dealing with concentration variances, etc. The bronchial circulation, the bronchial arteries provide oxygenated blood to the lung tissue itself. The nerves, the lungs are going to be innervated by parasympathetic and sympathetic nerve fibers. Most of these nerves are coming through what's known as the pulmonary plexus. Parasympathetic fibers tend to cause bronchial constriction, which is going to decrease the diameter of the bronchioles, whereas the sympathetic division is going to cause bronchial dilation, which means it's going to increase the diameter of those bronchial tubes to allow even more air. The pleura, this is the membrane, serosal membrane that divides the thoracic cavity, is surrounding the lungs. That to show it in just a second. There is fluid that fills the pleural cavity. That's going to help provide lubrication because the lungs obviously are moving. You want lubrication and reduce friction along there. And so when we're talking about the pleural membranes and cavities, this is what essentially is surrounding the lungs. It's a membrane around the lungs. If you have pleurisy, that is inflammation of these membranes. Sometimes it happens after a person has had pneumonia. It is going to cause friction. You're going to feel pain every breath in because that membrane is inflamed. So every time it's rubbing against the lungs, anytime you inhale and exhale, you will feel it. You may have excess fluid that needs to be treated. Sometimes you may have other fluids that will accumulate in the cavity. You may have blood if there's damaged blood vessels. You may have other filtrates that it can be indicative when you start to have heart failure, especially on the left side of the heart. Where do those fluids back up? In the lungs? And some of that fluid may ooze into the pleural cavity.